Good evening. I take pleasure in welcoming all of you on behalf of the PCOS Society of India. Today's webinar is on insulin resistance in PCOS and infertility, and it's been brought to you by the PCOS Society of India. There are going to be two speakers. I'm one of them, and Dr. Anantharaman from Bangalore is the next speaker. Just to introduce both of us, I will be the moderator and the speaker. I'm the clinical director from Women's Center Coimbatore and a member of managing committee in PCOS Society of India as well. And Dr. Anantharaman is the co-founder and consultant endocrinologist at Magna Clinics for Obesity, Diabetes and Endocrinology, ex-faculty at St. John's Medical College Hospital. And his areas of interest are comprehensive management of diabetic foot, pediatric diabetes, diabetic nephropathy, adrenal disorders, and medical andrology. And he has authored and co-authored several national speakers. We take pleasure in inviting you for the evening session. For a brief introduction of PCOS Society, there is a website that you can go to which will give you the complete information on what PCOS Society is today. And there is a lot of access for a lot of recorded lectures in there on infertility, PCOS, and related subjects. There will be publications from PCOS Society, which will be periodically available to all the members of the society as well. And an ongoing event is a free modules which are available for you, 6 modules which are available for you, at the end of which a certificate is available from PCOS Society as well. So those will be the modules which are available to you. And there are plenty of benefits of being a member of the PCOS Society of India. Reduced registration for all the academic activities, free access to all the recorded webinars, and past conferences and lectures are available online. Opportunity to participate as a faculty at the annual conference, an opportunity to contribute to the newsletter of the society, also opportunity to contribute to YouTube and other social channels. So it will be something that's worthwhile exploring for all of you there as well. And there is a website where you can check it out if you wish to become a member of the PCOS Society. And I think we'll move on with the presentations of Dr. Anantharaman first, and he will be talking about insulin resistance in PCOS at an endocrinologist point of view. Dr. Anantharaman.
Firstly, I'll start by thanking Dr. Mirudhubashini and Dr. Durusha for giving me this opportunity to speak at this meeting. So, we had a discussion just 3-4 days ago what I should speak and what Madam should speak. Actually, that kind of encapsulates the problem that we have in managing PCOS. Actually, so we all know that it is a troublesome problem, and several doctors take care of patients with PCOS through their lifespan. So, gynecologist is the main doctor, but then endocrinologists do. Sometimes when the endocrinologist is not available, physicians do take care. So later on, as patients with PCOS become older, so above 35 to 55 years of age, so several other specialists like cardiologists, nephrologists, all of them also take care. Not to mention pulmonologist, bariatric surgeon, etc. So basically, PCOS is something that affects the individual very badly. So we need to have some understanding across specialities. That is a basic bare minimum understanding. So I've tried to bring through this talk some gaps in understanding that may be there. So I understand that most of the listeners may be gynecologists. So I tried to address the gaps because I'm not going to talk about what is the diagnostic criteria for PCOS, because all of you are already experts at that basically. So I'm just going to talk about insulin resistance per se. So I'm going to talk about the link between insulin resistance and ovulatory abnormalities and or hyperandrogenemia. That is how insulin resistance causes or is associated with ovulatory abnormalities and hyperandrogenemia. Then I'll go on to speak briefly about how insulin resistance is quantified in the metabolic laboratory, so and in the clinic. So because this is of interest to all of us, because many of us measure insulin resistance, because when it comes to insulin resistance, clinically, all of us, most of us are clinicians, and we deal with patients in the clinic. So how do we measure it in the clinic, and what are the mistakes, and what do's and don'ts? So and then I'll speak more about management of dysglycemia in our patients with PCOS, and management of CVD risk in our patients with PCOS, which is something that gets ignored. I mean, we don't much think about it. We are more worried about hirsutism, acne, and other things, whereas PCOS is something that goes on for life. So insulin is a co-gonadotropin. So you must be, that's the in PCOS at least. So it is clear through a lot of research that when you reduce insulin level, the androgen levels decrease, and when you increase the insulin levels, the androgen levels increase. So this does not mean that it happens in normal individuals, but it does happen in women with PCOS. So there are several lines of evidence that insulin acting through its receptor on the ovary can actually increase the androgen levels. So it also has got an effect on the liver in reducing SHBG. That's also one of the, in fact, if you look at SHBG production, insulin seems to be the prime regulator of SHBG production. So if there is hyperinsulinemia, the SHBG levels are low, and free testosterone levels increase actually. So that is indirectly a way of causing more hyperandrogenemia at the receptor level. So I guess you know all that, but then I want to just emphasize these things actually. And also, what has been made very clear in the last 10 years is that there is insulin present in the insulin receptors are active and present in the brain, especially in the hypothalamus. And we don't know what the source of this insulin is, whether it comes from the periphery, which gets transported into the CSF, or it is produced locally in the brain itself. So if it is produced locally, for insulin to be produced, you need to have a glucose sensor. So is the brain sensing the glucose and producing insulin? This is a major mystery. So in various animal studies, we have recovered insulin from the brain. And, there are knockout mice where insulin receptor knockout is present in the brain, which causes reproductive abnormalities. So insulin resistance has an effect on the brain and hypothalamus. You all know that hypothalamus is very crucial for the reproductive function. You have the hypothalamo-pituitary-ovarian axis. So if you have hypothalamic dysfunction, which is associated with insulin resistance, you are likely to get ovulatory abnormalities. And last but not the least, what is common garden and known to all of us, we all know that when women with PCOS start exercising, reduce their weight, and do a lot of exercise, it restores their ovulation. And studies have shown that when you use insulin sensitizing drugs, the classical insulin sensitizing drugs are actually thiazolidinediones. So a lot of studies with troglitazone, which is no longer used. I mean, it was banned because of hepatotoxicity. Troglitazone, pioglitazone, etc., have shown that there is a dose-dependent relationship between insulin resistance and PCOS. So basically, when it comes to PCOS, a large part of PCOS problems are closely related to insulin resistance. So without insulin resistance, there would not be any PCOS. We can let us say it that way. So how does it happen? This actually encapsulates everything. So when you have insulin resistance, that directly leads to hyperandrogenemia because of the action on the ovary. So you do have follicular maturation, which is getting blocked at the ovary. And you can also have neuroendocrine disorders because of the effect of insulin resistance in the brain. So you can have an imbalance in the HPA axis, imbalance of the HPO axis. So it also causes abnormal metabolism. As you all know, insulin resistance is closely associated with metabolic syndrome, non-alcoholic fatty liver disease, etc. So individuals who have a lot of insulin resistance also suffer from obesity, hypertension, sleep disordered breathing, etc. So all those things also get added. So, but when it comes to reproductive health, what's more important is the reproductive failure in the form of ovulatory abnormalities and also your hyperandrogenism, which causes acne and hirsutism. So there is another thing that I would like to note when it comes to insulin resistance and hyperandrogenism. It is that the defect in insulin resistance is not at the insulin receptor itself. So you can hear in this see here in this graph, the insulin receptor is located at the surface, and the insulin receptor produces certain signals which are transduced by insulin receptor substrate 1 and 2. So you can see that when you do a lot of serine phosphorylation of this IRS1, it blocks the metabolic effects of insulin. Right? So one of the chief metabolic effects of insulin is to push glucose into cells. So the metabolic action of insulin become resistant if there is excess phosphorylation of the IRS1 serine. Okay, so and this is mediated by increased serine kinase activity, and also the serine kinase activity is associated with excess production of androgens, both at the level of the adrenal gland and the ovary. So you can see that P450, 17 hydroxylase, etc. enzyme is actually again activated if there is excessive serine kinase activity in the body. So somebody who has excessive serine kinase activity would automatically have more insulin resistance and also more androgen production. So it kind of overlaps together, this tendency for serine kinase to be active. So it's an intracellular mechanism, what is not visible to us basically. But what is very clear is many of these tendencies are actually genetic. Around 70 to 80% of PCOS is genetic. It is not acquired. So it starts very early in life. Obviously it can worsen whenever a person with PCOS puts on weight. The PCOS is actually at the genetic level. Most of the contribution is genetic. So that's why worldwide the prevalence of PCOS, if you see, it is uniform across countries. So whenever where there's an epidemic of obesity, it may increase slightly, but it is not relentlessly increasing, just like we would like to believe. So though there is an epidemic of obesity, there's not a huge increase in this thing. So let me come to some aspects of insulin action in the body. So see, you all know that insulin is produced from the pancreatic beta cells. So what does this insulin do? The primary function of insulin is to move glucose into muscle. So insulin is a very essential hormone in the body. In the absence of insulin, we get type 1 diabetes, we can get diabetic ketoacidosis. So insulin's life-saving action is actually stopping ketone production from the liver. So the next action is actually keeping the glucose normal, so not allowing the glucose to rise in the body. It is basically, insulin is required for muscle glucose uptake. So whatever meals that we consume, carbohydrates we consume, it get broken down into glucose. And when the glucose enters the body, the insulin pushes the glucose into the muscle cell and thereby removes the glucose from the body. And why muscle? Because muscle is the largest amount of tissue. In terms of weight, it is a very large amount of tissue, and all the glucose, the glucose surge that happens in the body, it goes to the muscle basically. And also, insulin action suppresses gluconeogenesis. So you all must have wondered, when we wake up in the morning, how come the blood glucose is normal? We have not eaten anything for 12 hours to 14 hours. It is because of gluconeogenesis. It's that the liver is producing glucose. So a smaller quantity of insulin is required to suppress gluconeogenesis. A higher quantity of insulin is required for moving the glucose into the cell. And also insulin stimulates lipogenesis. The glucose that is left behind after moving into the muscle gets metabolized. So there is free fatty acid production from the muscle and other areas. Free fatty acid production increases, and this free fatty acid gets stored in the fat actually. So it increases storage of energy as fat. So these are the primary actions of insulin in the body. So when somebody becomes or is resistant to insulin, what happens in the body? The body compensates by producing more of insulin. So beta cells, though they are few in number, there are about 1 million beta cells that we may have actually, but then they are very, very powerful. A beta cell is nothing but a glucose sensor. So how it works is that, it measures the glucose time to time. There is a receptor which actually transports glucose into the beta cell constantly, and the glucose and the beta cell is nothing but a glucose sensor. So when it senses that the glucose is rising, for example, after a meal, you had meals, and then after a meal, slightly there is an increase in glucose. So the beta cell comes into action and starts releasing a lot of insulin. And this insulin would push the glucose into the muscle, and it keeps the glucose very, very constant. So for a typical normal non-diabetic individual who doesn't have impaired glucose tolerance, you will find that the meal-related glucose excursion is not more than 30 to 40 points actually. So if their fasting glucose is say 75 or 80, it does not cross 100. Okay, so this is how effective the feedback mechanism is. It's one of the most well preserved, and unless you get diabetes, you will not realize how effective this mechanism is in the body. So we need to understand this because for understanding clinical measurement of insulin resistance. So how does one measure insulin resistance in the human body? So you know that the seat of insulin resistant quantitatively is the muscle. Okay, so how do we measure the action of insulin on the glucose? So this we do by something called as hyperinsulinemic euglycemic clamp. So that's the name of the technique basically. So what is essentially done is that you arterialize a vein, and then you measure the glucose constantly from the forearm, and then on the other forearm you actually infuse insulin. The purpose of the insulin is to actually stop the liver from producing glucose. You know that the liver keeps on producing glucose at all times, so you start giving insulin until the glucose starts falling. So how do you know the glucose starts, the hepatogluconeogenesis is stopped? Because in the absence of food intake, the only thing that maintains your glucose level is the liver. So constantly the liver has to produce glucose. So once the glucose starts reducing, you also give glucose through another drip actually. So, and you are measuring the glucose, and you are infusing insulin at a very high rate. So if you infuse insulin, the glucose will come down actually. So you do this until you reach a steady state. So, it is not done manually. I mean, there are algorithms, there's a computer which pushes the pump, etc. So these are well validated techniques. They have been in use from the early 1980s. So basically we basically assess how much glucose goes into the muscle. Okay. So if a lot of glucose goes into the muscle, okay, so it means that the person is highly insulin sensitive. So higher the glucose infusion rate, better the insulin sensitivity. The lower the glucose infusion rate, higher the insulin resistance and lower the insulin sensitivity. So this is the only way to actually quantify insulin resistance in the human body. Okay. See, all other methods of measuring insulin resistance are biased actually. So I'll come to the method that we use usually in clinic basically. So in the clinic, we use this technique called HOMA-IR. So HOMA-IR is actually done after a 12-hour fast when the person is having a stable fasting glucose. So the person should be at rest, should not have exercised, etc. Because if you exercise, the glucose goes into the muscle even without insulin. So one way of reducing your glucose is to exercise. So we all tell our patients with GDM to do a lot of exercise. So one of the purpose of exercise is actually push the glucose into the muscle. So the person should not be exercising in the morning. She should not go for a morning walk and then give the HOMA-IR basically. So at rest, you measure the glucose and insulin. So basically the insulin level is the level of insulin that is required to keep the glucose constant, because we assume that the steady state, what we achieved in the previous slide using the glucose clamp, the clamp study, has been achieved naturally. So there are a lot of caveats to this actually, because it does not measure insulin resistance at the liver. So though you have muscle insulin resistance, you can have liver insulin resistance as well. So the glucose clamp takes away the liver insulin resistance out of the equation. So you give adequate insulin, so you make the liver sensitive to remove the liver insulin resistance out of it, and then you measure only the muscle insulin resistance, which is quantitatively the larger contributor to insulin resistance. So it's not a very rigorous method. It is useless in the presence of beta cell dysfunction or hyperglycemia. Okay. So if somebody's glucose is 200, their insulin has to be 100. All right. So because the body has to compensate by producing more insulin. In fact, it is an indication that the beta cell have failed. The very fact that the glucose has increased means that the beta cells have failed miserably. They are not working enough. All right. But in the presence of beta cell dysfunction, HOMA-IR is completely useless. So if somebody has a fasting glucose of 103 or 104 and has high insulin level, we cannot call that insulin resistance because there is compensatory hyperinsulinemia which occurs actually. And also HOMA-IR suffers from imprecision. So when you measure HOMA-IR in the same individuals 5 minutes apart, so we would have heard a lot of our patients tell that, their glucometers are not working properly. They check the blood glucose and then 2 minutes later, they again check the blood glucose. It gives a different reading. This is called imprecision. Same reading done several times, repeated again, gives different answers. This is called imprecision. So HOMA-IR suffers from both imprecision and all these things. We can use it epidemiologically because when you use it epidemiologically, all these errors get papered over, basically. They get neutralized. There is one set of error, there is another set of opposite error. They get compensated. So you can assess for populations using HOMA-IR, basically. So is this population of individuals insulin resistance can be answered. But for a given individual, HOMA-IR or insulin and glucose are not a good measure of insulin resistance. So I'll come to the next question. Is insulin resistance more common in PCOS? So I have put this graph because it looks a little bit more confusing than usual. But I want to take you through this graph. Through this through this slide. So basically, the headline number, if you look at the top, is basically a meta-analysis performed of insulin clamp studies. So if you would like to know how much more women with PCOS are insulin resistant, the real answer you will get it from this study which has appeared in Human Reproduction. It's not a very old article. It came in 2016. Right. So when you look at the insulin resistance level overall, the mean insulin resistance is actually, when you look at PCOS as a diagnosis, all right? So diagnosed by any criteria, be it Rotterdam criteria or NIH or NIH Rotterdam or the any other criteria, PCOS criteria. So you will find that around 30%, approximately 27% reduction in insulin sensitivity is there when done rigorously. And the qualitative inference is that there is a large amount of insulin resistance, that women with PCOS have got a large amount of insulin resistance. So we are not sure that, it does not mean that is directly contributing to their PCOS, but there is a large effect of insulin resistance in these individuals. If you take women who are lean, around 20% difference is seen between PCOS and normal women. These are case control studies where they've taken body matched, weight matched populations. So when you look at a woman with the BMI of 32, you find that there's a 30% reduction between women with PCOS and women without PCOS. So when you look at older women, say 32 years of age, you find that they have more insulin resistance. So what this means is that obesity worsens little bit insulin resistance, age worsens it even more. Okay, and when you look at diagnostic criteria, that's also very important. So if somebody is diagnosed by PCOS by NIH criteria, that is, they have both hyperandrogenism and anovulation, they are likely to be almost 30%, a higher insulin resistance point of 3% is there in them. So when you look at NIH criteria patients, they have the highest amount of insulin resistance. So there is basically, you can understand from the way the patient is diagnosed, the amount of insulin resistance that they may be having. This again, I think this is a famous slide. You must have all seen it basically. So this is from Andrea Dunay's studies actually. So when you look at lean PCOS and obese PCOS, there's a comparison of insulin resistance. You can find on the y-axis milligram per kilogram per minute. This is actually glucose infusion rate, what we calculate in the insulin pump. What I want you to note is that the middle bar on the right-hand panel for lean PCOS and the leftmost bar among the obese patients. So basically it compares obese and lean individuals. Okay, so and they've taken those who have PCOS and those who are normal and those who have type 2 diabetes. So the insulin resistance that is seen in PCOS is similar to that of type 2 diabetes. People with type 2 diabetes, diagnosed type 2 diabetes, have got slightly more insulin resistance. But the most important thing, takeaway message from this slide should be that that a person who is having lean PCOS, somebody who's say 22 kilogram per meter square and having a diagnosis of PCOS, has a higher insulin resistance than a normal woman with normal cycles, but who's obese. So somebody with so when you see a girl who's 22 kilogram per meter square but has irregular cycle, her insulin resistance is as bad as a lady with 32 kilogram per meter square body weight. Okay, so in quantitatively, their insulin resistance is much worse. So what does this imply? This means that they are more likely to get diabetes. So they are closer to getting diabetes, and they are likely to have several metabolic abnormalities, though they do not look obese. Okay, so and typically physicians do not ask history of menstrual cycle. I mean, I started asking for history of menstrual cycle after I started my DM endocrinology course. Before that, I did not know what it was actually. Okay, so as gynecologists, you can actually pinpoint those who are likely to get diabetes. So that's where the assessment, your assessment will help a lot. So how to assess insulin resistance in the clinic? I'm saying that the HOMA-IR is really bad and it's imprecise and all. The best way to assess insulin resistance in the clinic is to look at the patient examination. All right. So you can have the patient have acanthosis nigricans and skin tags, and the patient can have central obesity or truncal obesity, a central body fat distribution, excessive subcutaneous and visceral fat. All these are indicators that the patient may be having insulin resistance. If the patient has several of these features, then it's highly likely that they have insulin resistance. Okay. But knowing that somebody has insulin resistance doesn't change anything, because we are not going to, we don't have extremely good tools to treat insulin resistance apart from diet and exercise, which we are going to advise to everybody. But if we find somebody with insulin resistance, we should emphasize more on these things. So coming to the elephant in the room, does measurement of insulin resistance add any value to management of PCOS? In my clinical experience, I do not try to measure insulin resistance in my patients with PCOS. It's not recommended at all. So if you especially measure only insulin level without glucose level, it is entirely useless actually. In cases where signs of insulin resistance are not evident and factors like high prolactin are in consideration. For example, we do get women who are normal weight, who have no signs of insulin resistance, but they have irregular cycles and they have slightly high prolactin also. We really don't know whether this person is having irregular cycles because of hyperprolactinemia or because there is PCOS. So we know that PCOS has an underlying element of insulin resistance. So in such patients, I quantify HOMA-IR to look at whether they are insulin sensitive or not. I use it very, very sparingly. Out of say 50 to 100 patients, I may use in 1 or 2 patients actually. So insulin resistance is basically a pathogenetic mechanism in PCOS, and it's not an endpoint of therapy. So we are not going to achieve anything by reducing, if you tell the patient that you have reduced your insulin resistance. Okay. So we would like to restore ovulation in our patients with insulin resistance. I think Dr. Mirudhubashini will talk about it in detail now. So we want to reduce the hirsutism and acne. We want achievement of fertility. And we want to protect in the long term against metabolic and vascular complications of PCOS. So impaired glucose tolerance and type 2 diabetes mellitus are huge problems in PCOS. So odds ratio, if you see a lady with PCOS, she's 4 times as likely as a lady without PCOS to develop type 2 diabetes. So the onset of type 2 diabetes can be surprisingly early, say before 30 years of age. So I really do not like to see patients get diabetes before 30 years of age. So emphasizing lifestyle modification very early on, say from 18 to 20 years of age, telling that you are at higher risk of diabetes. We need not scare them, but they should change their behavior from an early age so that we can mitigate these problems actually. So we should not have a lifestyle problem on top of a severe genetic problem in PCOS. So this is something that we need to focus on. And also, it's important to screen for type 2 diabetes at least annually in PCOS. Okay, there are a lot of women with PCOS who come to the fertility specialist who have been having irregular cycles for months together, but we don't have a glucose value. So this should immediately stop. So the ADA recommends that for those with Asian ethnicity, after the age of 20 years, we should look for diabetes at least every 3 years, even if their first test is normal. Like, for example, at 20 years of age, you're checked for diabetes, it's normal. And then again, you will check after 3 years minimum. But for a woman with PCOS, a reasonable thing to do would be to check for diabetes annually at least. So you can do a fasting glucose, you can do a HbA1c. We can do a 2-hour post-glucose challenge also. Okay, if you don't have access to HbA1c, if HbA1c is expensive for the patient, we can do a 2-hour post-challenge glucose also. HbA1c of between 5.7 and 6.5% is considered pre-diabetic. So if you identify a higher HbA1c in a woman with PCOS, take it very, very seriously and make sure that they are controlling their metabolism. So lifestyle modification to be emphasized at every visit, and aggressive management of diabetes has to be done. We should prefer metformin and insulin in those who are planning conception. And if attempted conception is a few years away and concern is mainly regarding dysglycemia and weight loss, I mean, they are having overweight and they would like to lose weight, GLP-1 analogs and SGLT2 inhibitors are a very good option. So GLP-1 analogs are hormones. GLP-1 is actually a hormone produced in the intestine that acts on the brain to reduce the appetite, and also it is a insulinotropic hormone. It releases insulin from the beta cell. Actually, it's basically a signal from the gut which tells the beta cell to produce insulin, GLP-1. So, and it's a very strong agent for reducing blood glucose actually. But we do have data using liraglutide where liraglutide, when used in 3 milligram doses, it is licensed for weight loss basically. So for those who are having obesity, we do not have studies in PCOS per se, mainly because women with PCOS can conceive. They are in the reproductive age group. The complaint of PCOS itself means that this thing. So there are a lot of ethical considerations, whether they will conceive or not, all these things. So they have not used this as this thing. But then there are ongoing trials. This particular ongoing trial is from Chongqing, China, and it's also from Italy. Actually, it's still recruiting, as you can see. I accessed this just a day ago. So, they are looking at these possibilities. So what about cardiovascular risk in PCOS? So the reason why I'm mentioning this is most patients, around 50 to 60% of the heart attacks in India happen in those who are below 50% of heart attacks happen below 40 years of age. So please do not think that the woman with PCOS who comes to your clinic between 20 and 30 years of age, is not at high cardiovascular risk. So they are at substantial cardiovascular risk because they can develop metabolic syndrome. They can have dyslipidemia. Metabolic, for cardiovascular risk. This is from JCEM basically. This guideline came out in 2010. So assessment of cardiovascular risk and prevention in PCOS. So you will classify somebody as at risk if they are obese and having PCOS, if they are smoking cigarettes, if they are having hypertension, if they have subclinical vascular disease. So for instance, if they have already somebody has done a Doppler and found that there is PVD, you should take it very seriously. If they have glucose abnormalities, and also if they have a family history of premature CVD. How often do we ask these questions in the clinic? So whenever we are doing a first assessment for PCOS, so it's prudent to get all these details actually, especially smoking history. So in cities, we are finding that a lot of women do smoke, and we need to ask them the smoking history, and it puts them at especially high risk actually. And at high risk, I mean, some risk is there if all these things are there. Very high risk is there if they have metabolic syndrome. What is metabolic syndrome? For metabolic syndrome diagnosis, you need to have 3 out of 5. So what are the 5? One is waist circumference, another one is low HDL, third one is high triglyceride, fourth one is your blood pressure, high blood pressure, and impaired fasting glucose or impaired glucose tolerance. So out of these 5 things, if somebody has 3 of these metabolic syndrome. So if you have a patient with PCOS who has metabolic syndrome, she is considered to be at high risk and of cardiovascular disease. In fact, metabolic syndrome is considered a risk factor for cardiovascular disease. So we need to focus our attention on changing their lifestyle, smoking cessation, and these are the LDL targets. So what are the interventions available to reduce cardiovascular risk is that statin is a very good cardiovascular risk lowering agent. So the LDL target should be less than 130. They just have a diagnosis of PCOS. If they are high risk with metabolic syndrome, we can keep a target of less than 100 LDL. So this is the target which we can keep, and we can initiate the patients on statin therapy. So other aspects of CVD risk management is blood pressure measurement. So please get a blood pressure recording in all patients with PCOS, because you might have seen patients getting heart attack while you're treating them for PCOS. I'm sure all of you would have experienced, actually. This could be happening to our patients. So unless you assess the risk and take proper action, get the help of a physician or an endocrinologist to manage these aspects, it will be difficult to manage these patients. So if they get a heart attack while you're doing IVF procedure, then it's going to be a problem. Okay. So consideration for antiplatelet therapy to be done, and stress management and counseling also is essential for PCOS therapy. So in summary, I would say that insulin resistance is a common soil for several problems of PCOS. So insulin resistance is best recognized clinically and does not require any lab tests. Having recognized insulin resistance, treatment of all insulin resistance related disorders is as important as treating fertility and hyperandrogenism. PCOS and associated insulin resistance are chronic diseases that improve with medical attention and persistent intervention. So PCOS treatment is a marathon and not a 100-meter dash, basically. So we need to be aware that patients may not sound very receptive when you first talk to them. But if you explain the chronic nature of disease to them and tell them that these all could happen to you, just keep the conversation going. Okay. So we cannot cure PCOS in one shot, actually, because it's predominantly a genetic disease. So saying that somebody has insulin resistance or somebody has PCOS is like telling that, they are a male or a female. It's not very open to, change, actually. So we can only talk about only some aspects of their behavior which they can change, actually. But continuous monitoring, looking at problems that could happen, is a pragmatic approach towards treating PCOS. So this is what is my take on PCOS. Thank you.
Thank you very much, and I think it was a very elaborate but very scientific explanation into what PCOS is for an endocrinologist and what insulin resistance is. And I thank very much for especially the part on how do you diagnose PCOS. I mean, how do you diagnose insulin resistance when you have a patient in front of you. And I think I'll move on to my slides, and at the end of it, we'll take the questions. Both of us will take the questions. Can I have my slides, please? Okay. Some of it, what I will be saying, may be a little bit of a repetition from what Dr. Anantharaman said, but I'll start out with it. It'll be very basic, very simple. What, as a gynecologist, we ought to know. How do we define insulin resistance? It's a state in which a greater than normal amount of insulin is required to elicit a quantitatively normal response. In other words, you have to maintain the insulin levels outside normal, inside the cell normal. The same way the glucose, it has to be normal inside and outside the cell. And if you require larger than an amount of insulin floating around to essentially achieve that, then it's called a state of insulin resistance and insulin resistance. The disease that we are talking about today is PCOS, and it's we still are. I don't think there's an absolute clarity about understanding what PCOS is, but there are some things we know for sure. There is a genetic and an epigenetic origin for PCOS. It's not a single cause and effect kind of a thing. Multiple genes are involved. Most of these are genes which are actually controlling either a hormone or its receptor. So any one individual can carry one gene or more than one gene, according to, if you do investigate them. And multiple environmental factors are also there, starting from in utero, excessive androgen in utero, to postnatal period, immediate postnatal period of time, a baby that's underweight or overweight, and especially adolescents, a child which is under a considerable strain or stress and puts on a lot of weight. is a classic example of what those environmental changes could be. And all of these can either diminish or exacerbate the PCOS phenotype. Because the genes are so different and the epigenetic changes are also so different, no two individuals with PCOS are going to be alike. They all have their individual combination of things that's happening in them. So you can expect them to be different from each other. And insulin resistance is PCOS, as he very lot of detail told us, is a post-receptor defect in phosphorylation, reduced tyrosine phosphorylation, and the channel towards serine phosphorylation. The glucose doesn't enter the cell, and there is a substantial decrease in the insulin-mediated glucose entry into the cell. At the same time, a significant increase in pancreatic secretion. So the mechanism is this. There is resistance at the level of the cell. There is increased glucose in the bloodstream. There is also increased insulin in the bloodstream because it doesn't enter the cell. And the beta cell responding to the increased glucose by pouring in more insulin. And now you've got more insulin floating around, the hyperinsulinemia, which results in an excessive signaling wherever an insulin receptor is present. And it can be insulin receptor, it can be a hybrid receptor, and it can be insulin-like growth hormone dependent receptor as well. And these receptors are there and all over the human body, and so the effect of all of these can be very varying as well. In the skin, you get acanthosis nigricans because of this. Ovary, you get hypertrichosis because of this, and you can even get a bit of a pseudoacromegaly because of this. But that, besides the point, is that the only pathology in PCOS? The answer is no. There is also a central pathology in PCOS. There are multiple pathologies in PCOS which act together to finally produce a phenotype of PCOS. The central pathology is something called the kisspeptin metabolism, which is being talked about in the last few years. This is upstream of the hypothalamus. So it's above the hypothalamus and above the pituitary. And that acts as a juvenile brake. Until the child is a certain age, the manifestations are not seen. But there is something called a pubertal accelerator when the kisspeptin mechanism starts acting on the hypothalamus and then on the pituitary. And the ratio in somebody who carries these genetic factors, the ratio of FSH to LH that gets secreted changes. There is more LH compared to FSH that is being secreted. FSH basically is something that controls the estrogen. By making it very simple, it's something that controls estrogen secretion from the ovary. LH controls the androgen secretion from the ovary. So this imbalance ultimately produces an effect of overproduction of androgens from the ovary. So the root cause is actually in both places. It's in the periphery in form of an insulin resistance and hyperinsulinemia, and in the center in forms of changed, altered LH-FSH ratio, both of which can have an effect on the theca cells in the ovary, producing too much of high androgens. So this becomes an ongoing cycle, the high androgen and the high insulin, both of which are in different proportion in different individuals, but one can potentiate another. The insulin can make the androgen to go up, androgen can make the insulin to go up. So both are in a hyperstate. Both hyperandrogenemia and hyperinsulinemia are part of it. So ultimately PCOS is a hormonal imbalance which is aggravated by metabolic impairment. So you have two different components, which is hormonal as well as a metabolic impairment there. And the insulin resistance in turn has an effect on every organ of the body, and you've already heard about it. Skeletal muscle, what it does, you've heard about. And it also has an effect on the adipose tissue, in which the adipose tissue starts the capacity of adipose tissues exceeded, and then TNF-alpha and free fatty acids start floating around, which has all kinds of effects on atherosclerotic diseases later in life. And the hyperinsulinemia has an effect again on the ovary, potentiating the effect of the LH, and increased androgens are secreted. The liver doesn't bind, it decreases the hormone binding globulins. Therefore, the androgens don't get bound to the SHBG, and more is free and floating and is effective in the periphery. And the adrenals also sometimes secrete more androgens. So on the whole, the pathology is increased insulin and increased androgens as well in these women in different proportions. So there are some that you see with increased insulin, they present slightly differently. There are some who present to you with increased androgens where the presentation could be slightly different as well. So this is what it does for an infertility. The metabolic things we've heard about in detail, but what it does is infertility is the next thing. In infertility, what we have to understand is that the primordial follicles, which a woman carries in actually millions earlier in life, are still there in the ovary in the reproductive age group, but the primordial follicles then progress to primary, secondary, and then the small antral follicles. These small antral follicles are what we see when you do an ultrasound, pick up the AFC numbers in an ovary, and the same small antral follicles are the ones that are secreting AMH as well. So this AMH also, more AMH gets secreted, and the AMH has a very interesting effect on the fertility as well. The AMH blocks the effect of FSH on these growing follicles. The right side of the graph, what you're seeing is the follicles that have a potential to grow. That is after the small antral follicles. They are the ones under endocrine control. They are the ones under gonadotropin control. So whatever we do to manipulate the cycle with oral ovulogens or with gonadotropin can only act on small antral follicles. But there is something that acts on primordial follicles and brings them to small antral follicles, makes somebody into a PCO. That is paracrine control. And when gonadotropins are not controlling these primordial follicles and making them progress, it is the very same two things, which is insulin and androgen. So insulin or androgen are responsible for making the primordial follicles into small antral follicles. So the more of these substances which are floating around, the more number of small antral follicles you have, the ovarian volume becomes more number of antral follicles are there. But however, they become less sensitive to FSH and you have all kinds of problems when you're stimulating them, even with gonadotropins. You'll find that sometimes they will not respond to you until you reach a certain level. But if you keep increasing the gonadotropin levels, all of a sudden, all of them will blow up in your face and you will have an OHSS on your hand. So this is very, very important because it again says why it is important for us to limit the androgen effects and limit the insulin effect on the primordial follicle if we need to make the small antral follicle numbers less. So the underlying pathology is varying degrees of expression of insulin resistance and hyperandrogenism, resulting in varying phenotypes, and that's what we have to remember, that all of them are not going to look the same when they walk into your office. Clinical manifestations of insulin resistance can be truncal obesity, metabolic syndrome, acanthosis nigricans, skin tags in the neck, non-alcoholic fatty liver, sleep disorders sometimes, and psychological disorders sometimes. But this is almost something that declares to you when the patient is in front of you in your office, the clinical manifestations of insulin resistance. And you've already heard how clinically what you pick up is as important, if not more important, than anything that you do in the laboratory. And complex tests involving insulin measurements are really not practical for all of us. And therefore, I think we are dependent on the clinical examination and picking up all of these indicators which tell us that there is a significant amount of insulin resistance in this individual. Hyperandrogenism, on the other extreme, it is cutaneous manifestations of hyperandrogenism, which can be the typical hirsutism, androgenic hirsutism, and or very severe acne. Both can be a little bit normal in puberty, but not to a severe extent. And when you have them for us in a severe extent, I think that can be indicative of hyperandrogenism. So what you look for is indicators of hyperinsulinism and indicators of hyperandrogenism. May be different in different individuals. The lean PCO with a high LH who's producing more of ovarian androgens will present with hyperandrogenism. The other side where the peripheral metabolic effects are there, insulin resistance effect are there, will present you with hyperinsulinism and the sequelae. So these are the things that you see with hyperandrogenism: hirsutism, acne, alopecia, higher waist to hip ratio, detrimental effects on the follicular growth and anovulation, menstrual disturbances. But what about obesity? We haven't even talked about obesity. Isn't that a part of PCOS? Should we have obesity to diagnose PCOS? The answer is not every PCOS is obese, And not every obese person that's sitting in front of you has PCOS either. So there is a considerable incidence of it, but this is not important for you to make a diagnosis of PCOS. It doesn't come into the criteria, the Rotterdam criteria, or the modified criteria, or any of the other criteria that we've looked at and talked about. So obesity should not be taken as an indication of PCOS. Having said that, I would say that abdominal obesity is still important because that can be indicative of insulin resistance. And obesity-related insulin resistance also is there. And it's sort of an interesting pathology. The enlarged adipose cells whose capacity gets exceeded, and there's a high serum free fatty acid level, and this gets deposited in the muscle and the liver like we talked about. Macrophages get attracted to this dystopic fat deposition and start phagocyting these adipocytes. And what happens is that it initiates a low-grade inflammation. In today, when we are talking about the clinical pathology of PCOS and insulin resistance, we also talk about a low-grade inflammation because that has a lot of adverse effects when you're starting to treat people. This inflammation can be a very, very important thing and something that we have not paid much attention to earlier, because you can see now, with the COVID-19 going around, how much of disaster inflammatory responses are causing. So PCOS, majority of them have a constant chronic low-grade inflammation as well. And the adipokines, adverse adipokines in TNF-alpha make it worse, and there's a decreased production of protective cytokines in adipokine. So it's like a double-barrel gun. When you have a PCOS and obesity, both increase insulin resistance. And on the whole, when you have an individual like this, the insulin resistance with the BMI going over 30, it's quoted as 70 to 80%, but it can be much, much larger than that. But when you come to the individual with a very low BMI, the part that hyperandrogenism plays is much more important than the insulin resistance, though even in those individuals, like it's already been stressed by Dr. Anantharaman, insulin resistance cannot be ruled out, and you have to take it into consideration and make sure that they don't run into problems later in life. So whichever comes first, is it insulin resistance or obesity? This is like chicken or egg, and one can lead to another, and one can make that other worse as well. So both together in a PCO situation is really not great. And the programming in of all of this with this comes to us with different clinical problems in different stages in life. Around adolescence, it is the androgenic problems that can take precedence. It can be hirsutism, it can be acne, it can be adipose tissue and obesity indicative of insulin resistance as well. So these are the things that can come to you. The young individuals can come to you around adolescence. A little later in life, we also see the infertility patients for the first time presenting to us with what we call a polycystic ovary. But the two things to note is diagnosis is not made on the basis of adiposity, and it's not made only on the basis of an ultrasound picture of an ovary also. And I think these are very, very important points that we have to take back home. The pathology is different. It is not the ovary. Ovary suffers out of it, and that is not the causative part of it. So treating the ovary doesn't resolve the polycystic ovary syndrome. It's treating the metabolism. Management, of course, we know that, first of all, it's non-pharmacological management in all of your patients. Lifestyle, reduced carbohydrate, exercise, and reduction of hepatovisceral fat. Behavioral strategies are extremely important because you can say all you want. If you're spending just 5 minutes with that patient, she's definitely not going to do anything. So this is where the PCOS clinics come into play. And it's got to be goal setting, self-monitoring, stimulus control, problem solving, assertiveness training, slower eating, reinforcing changes. And you need people to spend the time with them and who can sort of discuss with them about all of these things, including psychological problems, if you were to produce any difference in how you manage them. So the management concerns, especially in adolescents, when they come into your office, the desire for the patient and her family is that for an immediate improvement of the presenting symptoms. That is the focus of the patient, young patient, and her family. Menstrual dysfunction and hyperandrogenism is what is particularly distressing for them, and that's what they come to you for. But however, just like Dr. Anantharaman said, the factors associated with later metabolic risk may not be a concern for them, or the family, and it's up to us to bring it into the conversation, emphasize this point of view, monitor them all through the life, even if they don't have proof of it at that period in time, and deal with it as early as you can. So, and what do we do when they come in with hirsutism or AUB, irregular cycles, and ovulation? Usually in adolescence, the management becomes COCs or combined oral contraceptives, which contain estrogen and progesterone as the first-line treatment, first-line pharmacotherapy in adolescent PCOS with abnormal menstrual bleeding and or cutaneous signs of androgen excess. I'm not going to go into details. We've already done it in some of the other sessions. So it is basically COCs, which are pharmacotherapy in the first place. But what we have to emphasize again is that these deal with symptoms. They don't deal with the underlying pathology. So that is something that we have to remember, and we have to keep reminding the patients as well. So the management of PCOS does not stop with managing irregular periods and or hirsutism. The second thing that we have to worry about is not just that there is an underlying factor, which is insulin resistance and hyperandrogenism, but there are adverse effects of COC. COC is not something that is risk-free. There are metabolic side effects, venous thromboembolism, so the numbers are small, but it still is possible. Thrombotic strokes, MI, salt fluid retention, impeding of weight loss. If you keep giving them COCs, many of them, different combinations may impede weight loss. And pre-menarchal girls, you have to be very, very careful. The short stature especially may have a risk in growth inhibition. But however, it does not produce an increase in post-pill amenorrhea or infertility later. So that is not a negative part of COC. But there are enough other things that are happening with COC in a longer period of time that we have to think about the potential risks as well. But we do use them, and we have to use them because the benefits at that stage in life, OCPs, outweigh the potential risks. So the debate is, do benefits outweigh? And if both are there, how long is long enough? How long do you put them on OCPs? And the optimal duration, has anybody decided what the optimal duration is? But what you find in the literature is that if you diagnose this in an adolescent period of time, you have to continue the treatment until the patient is, within quotes, gynecologically mature. This is defined as 5 years post-menarchal, or has lost a substantial amount of excess weight. This is also something that you have to watch. If you are able to make them lose the excess weight and bring their insulin resistance under control, then it may not be much of a problem. So metformin, when it comes to us, is already talked about it, can help in weight reduction. Combined with OCP, the effect of lipid profile and BMI balances the negative effects. But it cannot be used alone for insulin sensitizers. This is another important point I just want to make. I think the time is up, so I'll have to probably wind down. ASRM guidelines for usage of metformin. I'm sure all of you have heard that there is insufficient evidence for the benefit of metformin in inducing ovulation, in preventing miscarriages, in preventing multiple pregnancies, and prevention of pregnancy complications. It does not increase ovulatory rates and pregnancy rates. And after you've heard Dr. Anantharaman and me, now you must be wondering why use metformin. But it cannot be, what needs to be said is that it's not used for symptomatic management, but it's used for the pathology which is underlying. It cannot be used alone for a short-term management of symptomatology. It will be useless. And you have to use it anywhere from 12 to 24 weeks if you need to find any changes in the symptomatology. And myoinositol, again, has been used, and there is a lot of information about it today. The combination of myoinositol and OCPs, which is becoming more and more accepted, but still a lot more studies need to be done to equate it with metformin. The one thing is it's less expensive, time-tested for long-term use, metformin, whereas myoinositol is expensive, newer drug than user-friendly. Thiazolidine, I will not go into this. I think you've already heard about it. The glucagon-like peptide receptors, it's now no larger studies are there. So concluding, insulin resistance is a major factor in development of PCOS. Significant percentage of patients, but not all, have evidence of insulin resistance. Insulin resistance is responsible for adverse long-term effects, and in managing PCOS, active effort should be taken for diagnosis and the management of insulin resistance. Both pharmacological and non-pharmacological therapy may be necessary and should become an integral part of PCOS management. Thank you. Is there time? Can I go ahead with one or two slides? Okay, there is some interesting information in recent studies how they found that the metformin used ahead of time prior to a pregnancy, like Dr. Anantharaman said, helps in reducing early pregnancy losses. And those are studies involving trophoblast cultures outside and seeing the activity of insulin on it and metformin on it. And there's another study that looks at chromosomal genetic studies at a level which is far more developed. And those studies are also showing that hyperinsulinism can have an effect on genetic study of a growing embryo in the early part of pregnancy. Thank you. I thank Dr. Anantharaman and I thank the PCOS Society for making this possible. Most of all, I thank the online delegates and Shield Healthcare, especially for their support in hosting this conference, and the web stream for their excellent technical assistance. I think we'll look at some of the questions. How fat affects the insulin resistance as for PCOS? Low-fat diet is recommended. Dr. Anantharaman, do you want to answer?
Ma'am, question again?
How fat affects insulin resistance in PCOS? I think I've given the answer, but you can go ahead.
Fat in the diet, ma'am. The dietary fat, huh?
Yeah, dietary fat or somebody who's...
there are a lot of misconception about dietary fat, actually. Now there is a movement towards... a low carb diet, which is culturally happening with our patients, etc. See, earlier when there was an epidemic of cardiovascular disease, we used to blame the dietary fat for the high LDL levels that were the cause, were tied closely to cardiovascular risk, basically. Now we have statins, and statins can control the LDL very nicely. And we also know that not all dietary fat is bad. So more important thing to note in PCOS is actually calorie restriction. So unless you have calorie restriction, you are not going to have any weight loss, and weight loss is one of the goals. But when you look at lean PCOS, etc., even in those individuals, it's imperative that we don't give too much of carbohydrate, basically. So if you give too much of carbohydrate, then again you worsen the insulin resistance. So the recommended diet, the prudent diet, what is recommended by ADA is actually to keep the carbohydrate between 50 to 60%, say around 20% of fat and 20% of protein. So 20% fat is actually more than the fat that we consume in our diet, actually. But then, when you reduce the carbohydrate, when you reduce the overall calories, it's recommended that we remove only the excess carbohydrate, basically, the extra rice and other things. But we need not discourage the patients from eating the fat in the diet, because fat is very essential for satiety. So unless they have a little fat in the diet, it becomes very difficult to actually keep the total calorie count down. Actually, the appetite, the appetite goes up, and then the patients find it difficult to, control the hunger. So they end up eating, and then they again put on weight.
Okay, thank you. Is there any correlation between lean PCOS and insulin resistance? I think we've already given the answers in our talks. Yes, there is. Lean PCOS can have insulin resistance. It may not be as striking in clinical findings as it is in obese PCOS, but however, you still have to keep looking for it right in the beginning, as well as ongoing care. During ongoing care, the yearly checkup should be important, and you have to keep that in mind always, even in a lean PCOS. Insulin resistant and non-resistant PCOS diagnosis and management. Diagnosing PCOS is different from diagnosing insulin resistance. PCOS diagnosis is made, as far as gynecologists are concerned, even today with Rotterdam criteria. the three criteria, all of them to be fulfilled in an adolescent, and at least 2 out of the 3 in an adult. So the defining it and diagnosing it does not change, but however, management changes, and you have to look for insulin resistance in each one of the PCOS that you're treating. And we cannot forget about the underlying factor. Symptomatological treatment alone is not enough. You have to look for insulin resistance and activate it when it is there. PCOS in a slim person, how the definition does not change of PCOS in a slim person. Why it becomes very difficult to lose weight with PCOS? Why we feel changes in inches but not in weight? What are the natural remedies to cure and reverse PCOS? Dr. Anantharaman?
Yes, ma'am. This is actually the problem which is not unique to PCOS actually. So because many of my PCOS patients who come to me for consultation ask these very same things. They come and tell me that, because of my PCOS makes it very difficult for me to lose weight. So my answer to them is that anybody who's overweight finds it difficult to lose weight actually. So it is not that PCOS alone. So obesity itself is a very poorly understood disease. Why people gain weight, we do not know. So it's usually multifactorial. So behavior, mood, physical activity, food intake, all of them are bundled together and cause obesity actually. What I see in my clinical practice, where I practice in Bangalore, is that, my patients who come in with PCOS when they are, say, 23, 24 years of age, they join the software company and then they are working, and over a period of 2 or 3 years, they relentlessly gain weight. This is because of long hours, long commute in our city, and there's a lot of stress. There's a stress on sleep also. They do not sleep adequately. And of course, eating out is very common. The food intake is very common. They socialize with their friends over food only. So there are a lot of cultural changes. I would say that obesity itself is a cultural disease rather than any other thing. So because they stay in a particular place, we are having a obesogenic culture. That is the reason why people get obese actually. So there is a tendency towards not doing exercise, not doing not controlling your food intake. These are to a large extent been normalized actually. So see, nowadays, after finishing a day's work, it's very common to go out to a restaurant and have food and not do any exercise basically. Okay, so these problems we need to understand as physicians that these complex interactions are responsible for obesity. It's actually a very difficult thing. We should not use the same language that the patients use. What I feel is, if we use the same language, we will not be able to answer them basically. I find it difficult to lose weight. Everybody with obesity finds it very difficult to lose weight actually. So we need to change the language. We need to tell them that change your behavior. Okay, make slight changes on a daily basis. Eventually, you will find a response. Why do we need to? What are the natural remedies to cure or reverse symptoms of PCOS? I don't think the natural remedy, the best natural remedy, is actually diet and exercise. Actually, there are no other natural remedies that I know of. So, they have not been proven in any studies that there is any natural remedy that actually works specifically to reduce insulin resistance. That is actually the holy grail of our medical science. The moment we find that, our problem is solved.
Okay, I think with that we are running out of time, and I think we have, even though there are some more questions, I think we'll have to complete this session. And I thank Dr. Anantharaman a lot from our point of view and from PCOS Society. I thank online delegates again, Shield Healthcare for their support in hosting, and the web stream for making the technology possible for us. Thank you very much.
Thank you, ma'am. Thank you.
Okay.